Hello, I'm Norbert Gleicher, MD. I'm the Medical Director and Chief Scientist here at the Center for Human Reproduction. With me today, David Barad, our Head of Clinical IVF, and our Director of Research here at the Center for Human Reproduction. And one of the questions we want to address today that comes up all the time is SART outcome statistics. And frankly speaking, it's not only SART, it's also CDC, Center for Disease Control outcome statistics. So paradoxically, we here in the US have two separate reporting sites. We, under law passed by Congress, like every IVF clinic in the US, have to report our cycle outcomes to the CDC. There is no mandate to report to SART, and therefore SART, the SART registry has a small number of, slightly lower number of clinics reporting to it. But we have basically two separate reporting authorities.
So the thing to understand is 95% of clinics are reporting through SART, which is a subset or organization of our National Fertility Society.
Of the American Society for Reproductive Medicine, a sister organization.
And so the data that goes to SART, that ends up being their statistics, and the data that goes to the CDC, which is presented as statistics, it basically is the same data set.
Yeah.
They're presented somewhat differently.
Yeah.
But they're based on the same basic data set.
But they do not necessarily represent the same centers. There are more centers, a slight number of more centers reporting to CDC, where it is mandated, then are reporting to SART. But it is basically the same.
When you look at an individual center's report,
it will be the same.
It's the same data set.
Yes.
And there is no adjustment in SART statistics for the populations that different centers are caring for.
Yeah, and I'm glad you're raising this at the very beginning of our discussion here, because it is very important to understand for the public or for anybody who is interested in outcomes in medicine in general, that outcomes are always dependent on in whom they are investigated. In other words, if you, for example, study coronary bypass surgery in 40-year-old men, you will have a radically different outcome from studying coronary bypass surgery in men with the average age of 75. And that has been widely accepted in medicine, and therefore when large-scale outcome studies are done, they are usually statistically adjusted for age and other characteristics of study population that can impact. Paradoxically, in infertility reporting, that does not always happen. And to say it politely, not often enough.
So the SART statistics and the CDC statistics are generally broken down only by age. Mm-hmm. And as many of our patients know, age is not necessarily a protection against having problems of ovarian reserve. We see women in their 20s and 30s who have significant problems.
You can have old ovaries, old behaving ovaries when you're young, and young behaving ovaries when you're old. Yeah. Yes.
And so, this is a problem. The average patient that I see is a new patient comes to us with their reports of the 5 previous clinics they went to that failed to help them achieve pregnancy. So the population we're dealing with is somewhat different than somebody who's coming in for their first treatment.
Yeah,
so,
not only somewhat, but we are probably the prime example in the U.S., if not in the world, in negative patient selection here at the Center for Human Reproduction. And maybe this is the time to communicate a little bit about what is so different between our patient population and the average patient population. And it, of course, starts again with age. The average age in U.S. reporting clinics for a decade or longer has been stable at age 36, which is also interesting because in general, fertility populations are aging. Mm-hmm. That population has remained static because what has remained static is that after 42, 43, most IVF clinics sent their patients into egg donation. Mm-hmm. So that stabilizes the median age at age
IVF population
36. Yeah. In contrast, our patient population really has been getting older and older from year to year and hit 45 median age, meaning that over half of our patients were over 45 last year in 2024. So that is already a quintessential difference. And for us, that obviously means that our outcomes have to be different than the outcomes of...
So when you're looking at SART statistics, for instance, over the last 5 or 6 years, SART has moved in the direction of cumulative pregnancy rates, meaning that a patient produces X number of embryos in their first cycle. The embryos are selected on some basis and frozen, and then they're transferred 1 or 2 at a time through a series of cryopreservation cycles. And then they look to see what the incidence of pregnancy is per retrieval.
Per retrieval involving all the eggs and embryos that are produced in one cycle, which is actually an interesting and correct parameter to look at.
In our case, our patients generally don't produce enough embryos to freeze a lot.
Yes.
So our cumulative pregnancy rate and our per cycle pregnancy rate ends up being about the same, just based on the patient population.
Yes. We are happy if we have enough embryos to transfer, because as patient gets older, everybody is, of course, willing to transfer more than just 1 embryo.
Now a center that's dealing with what we'll call general population and fertility patients these days probably needs to get about a 35 to 40% pregnancy rate to be in the median across the country. Yeah. Mm-hmm. But we are taking care of patients who failed on those 3 or 4 or 5 previous cycles.
Yeah, this is another point that this may be the time to make, that over 95% of patients who come to us as new patients have previously failed 1 or more IVF cycles elsewhere. That is unmatched. I mean, that is probably even more different than our age difference from most other IVF clinics. And obviously, if you deal with patients predominantly who have failed several IVF cycles before, often in several different IVF clinics, the expectation of pregnancy success is much lower than a patient population where you have in a majority first cycle patients.
So we're thrilled if we're getting a 10 or 15% pregnancy rate in this population.
Of course, we are thrilled, and we have kind of a cumulative way of looking at our progress in what we do. Because if you add into this not only that our patients are so much older, that they come to us after they have failed so many cycles. And if you add to that over half of our patients come to us after they were told that their only remaining chance of pregnancy is through third-party egg donation, and they come to us because they don't want to use donor eggs. If you consider all of this in our patient population, the question obviously arises. So what happens when these kind of poor prognosis patients come to a center like ours? And when you look at the data cumulatively, and here's the answer, because we have been doing that now very carefully for several years. And first of all, it is very important that you need to recognize that amongst this kind of a patient population, quite a lot of patients will never make it to an embryo transfer because they either don't have an egg, or if they have an egg, that egg or those two eggs they have don't fertilize or don't make it to a transferable stage, which in our clinic anyhow is different from others because we transfer these patients already on day 3. We don't even culture them to blastocyst state. So you have to remember that you cannot really automatically refer to your outcomes based on cycle start. You have to establish a different kind of criteria. And what we have done is we have said, okay, let's look at our patients where at least one embryo makes it to a day 3 transfer, which is a very low outcome parameter. Only one embryo in a 45-plus-year-old woman obviously does not give you a great pregnancy chance. But that's our criteria that we have been following now for several years. And there, our results are actually pretty damned impressive because we, in 3 years, have increased our ongoing pregnancy rates, which are almost equal to live birth rates, by a full third. In 2021-22, our rate was roughly 8%. And last year, in 2024, we hit for the first time a 12% pregnancy rate. So if those women had only one embryo for transfer, and that was even a day 3 transfer, they had a 12% pregnancy chance. And that is really, really remarkable. And I think we can be very, very proud of that. Anything else we want to say about the reporting systems? Maybe an important point is that both ASRM and CDC in their reports actually make all of that very clear. Mm-hmm. Because while they are not explaining it in as much detail as we have just done, they very clearly state that those statistics between clinics should not be compared because different clinics have different patient populations. And that is a very, very important point to make. Anything else?
No. If you have specific questions about specific SART statistics, you can bring them back to us, and we'll be happy to talk about them more in the future.
Any questions? You know how to reach us. Thanks for listening.